Good afternoon, or good morning, depending on which coast you're on. This is David Nace, and I'm pleased to welcome you today to our webinar, Welcoming the New Age of Healthcare's Digital Transformation. Man, what a timely topic we have. And to meet such a timely topic, I'd like to introduce our panelists. First of all, welcome my good friend and longtime colleague, Dr. David Nash, founding Dean Emeritus at Jefferson College of Population Health, and the Dr. Raymond C. and Doris N. Brandon, Professor of Medicine at Jefferson University School of Medicine. David has an MBA from Wharton School of Business and an MD from the University of Rochester. David, welcome.
Thanks. Great to be together again, David. And so it's the two Davids, and then we invite other people to the party.
Awesome. And also pleased to welcome Michael Camacho, who's the Division Vice President of the Clinically Integrated Network, CHI Texas, part of the CommonSpirit enterprise. Mike has a long history of working with ACOs and Clinically Integrated Network. Prior to being at CHI, he was with Premier Management Company, about a 350 MD Medicare ACO, Population Health Company, and Covenant before that, doing Clinically Integrated Network. He's been at this a while, and from what I understand, usually very successful. So, Mike, welcome.
Thank you so much. Happy to be here.
So I will be your moderator today. I am the Chief Medical Officer here at Innovacer, where we offer a set of cloud-based products and services to help your organization digitally transform, and that's to help you innovate and create that future of medicine, particularly population health and primary care being the foundation of both. So let's get into it, because this issue of digital transformation is really important today. So I'd like to start off with you, David. It seems like the pandemic, now that we're encroaching upon a year and 500,000 lost lives, has really impacted our ability to deliver care. Can you speak a little bit about how the pandemic has really affected care delivery in the United States?
Sure. So first of all, great to be together. And Michael, welcome to the David Nace, David Nash show. We love to have you. And special thanks to all the attendees who are carving time out of their busy day. We really appreciate that. So David Nace, wow, you know what? We should take a moment just to reflect on 500,000 deaths, right? I mean, it's almost hard to talk about. As a student of the Second World War, this is just, it's amazing to me. Imagine if some foreign nation had killed 500,000 Americans. I mean, we would be in a global conflagration over that. So we're in a global conflagration, but over a tiny piece of RNA. So look, Paul Batalden 20 years ago was famous for saying every system is perfectly designed to achieve the results it gets, right? And he based that on the work of Edward Deming from 1950. And so I'm of the mindset that, as you and I have chatted about, you know, raise your hand on part of all of our wonderful attendees if you believe that the failed system that brought us to the brink of disaster is the same system we need to, you know, take us successfully into the future. Putting aside the amazing bravery and valor at the bedside, we're not questioning that. Of course not. I'm married to a doctor. I have a daughter who's been on the front lines as a attending physician since day one. So I get it. That's not what I'm talking about. I'm talking about system failure. And our system was never designed to achieve its most important goal of improving and maintaining health. I would argue the system was designed to do exactly what it does: acute and chronic care of acute and chronic problems, do as much as possible, grab your share of the market. I mean, what's our North Star? What's our core goal? So that's the big picture. I also think at the ground level, it's changed everything. Of course, we're going to talk about digital health. We're going to talk about maybe, I hope, reducing waste. We're going to talk about, as this slide says, the road to value-based care. Why don't we address that just for a moment? there's a lot of sentiment out there that the road to value-based care is roadblocked, and that why should we bother now? What we really need to do is kickstart the engine that's been idle for a few months, and get everybody back, and do the procedures, and get the orthopedists busy, and get people back into the cath lab. I get it, but that's not the solution. The solution is we've been given an unbelievable opportunity so those 500,000 people didn't die in vain, to rethink about what we really are about as America's largest, and I would argue most important industry. So David, it's changed everything, and I remain optimistic for the future, only if we take advantage of this incredible opportunity to implement change. So that's my long-winded answer to get us kicked off today.
No, underscore that last point. And, the pandemic really did, demonstrate the frailty we had in the system that we, have been dealing with for as long as we all can remember. So one of the things that it did do, and I'd like to get Mike's point of view here, is change the expectations of how care is delivered. Mike, can you share a little bit about your experiences over the past year with how patient behavior and expectations may have changed?
Yeah, certainly. It's been significant. I think we've all dealt with huge changes on how care is delivered, and access to patients. I know this time last year, we started seeing the numbers go up, but it really didn't take effect until fast forward 3 or 4 more weeks. We'll be at a year anniversary. And it was kind of that spring break that never ended for those of you who have school-age children. And so for us, I know locally in Houston, one of the things that we saw that was dramatic was just the impact and the stay-at-home orders and things that took effect, where, being in Houston, Texas, the 4th largest city in the United States, everything grounded to a halt. And I'm sure that happened in many of the other hotspots. And as this progressed throughout the months, everybody saw that same type of grinding to a halt. And one of the things that we had to quickly address and amass is, how are we going to engage our patients? Do we still need to focus on elective procedures? What technology exists? Even the payers were catching up on trying to help support and compensate providers providing virtual care and virtual visits. And so we saw a huge decline in patient volumes. We were even tracking how much activity was on the freeways. One of the real innovative things is you could track a correlation between COVID activities and spikes, and then how many people on the roads, what's the rush hour like coming at home. And there was a significant correlation. And like I said, being in the 4th largest city, and your commute normally takes an hour and 20 minutes to get to work, and it only took 30, something's going on. And so I think for us, the pressure was placed on the healthcare industry to figure out a process to re-engage patients, and to make sure that you provided not only superior care, but also reassure them that we're going to get through this. And some of that was done through virtual visits. Some of that was capacity. We had to, many of our facilities converted over entire units to support COVID care. And that still goes on to this day. We even had our children's hospital here at Texas Children's started admitting adult patients to care for COVID because it got so bad. So I think as far as that shift, it happened. It's a tough lesson to learn, but I think we're all better for it. And the folks that I really did see start struggling was not the large health systems and the employed doctors. It was a struggle, but I think even today there are independent providers who need further assistance, or their practices aren't going to survive. And we've got to do our part as a physician community, as a clinically integrated network to support them. So it's been substantial.
And David, I know you've had a tremendous shift toward these virtual techniques, engaging patients. Where do you think that's going to go in the future?
Yeah, so I was listening carefully to Mike's wonderful answer. I wish I could take credit for Jefferson Health, our 14 hospital, $5.5 billion system, but with leaders like Dr. Steve Klasko, Dr. Judd Hollander, Dr. Bruce Meyer, Dr. John Gleason, the leadership team. I mean, we were doing telehealth, digital health way before the pandemic. So from an operational point of view, we were ready to wind it up and get it out there, educated 1,000 doctors on how to do telehealth. And I think the pivot was pretty incredible. But let's connect some dots here, David Nace, and Michael's nice answer. And if you go to the previous slide about value-based payments, so here's what I've learned. Physicians who made fun of per member per month payment never wanted to be part of any kind of capitated value-based world. Then came the pandemic when their doors were closed, and all of a sudden getting that per member per month payment sounds pretty good. So folks who wouldn't give yours truly the time of day to learn about what's an ACO now are pretty excited to learn about value-based payment. While the delivery system may have its own issues with value-based payment at the individual practitioner level, I think we've seen a burgeoning interest in what does it mean to get paid to improve health. So we're going to have some cultural challenges even by this summer, hopefully certainly by a year from now, when we're largely back to normal. What is that going to mean at the individual practitioner level? There's one thing about doing telemedicine, and it's another thing to totally change what you've been doing as a provider for the last decade or two or three. And I think that's another important impact on care delivery that we need to mention here.
Yeah, so there's been a lot of barriers that both of you, in your experiences, to really innovating. And I know that Jefferson, you've done a lot, and CHI, you've done a lot, but barriers still exist. Michael, can you talk a little bit about what have been some of the historic, particularly pre-pandemic, roadblocks to innovation within the organization?
Yeah, certainly. So CHI Texas, large division, 16 hospitals. Much of that came together within the last 5 years. So CHI moved into Texas, 6 years ago, purchased one hospital, and then subsequent years purchased more outlying hospitals that service about 22,000 square miles. Up until the point of the pandemic and everything really happening and taking shape a year ago this time, we were very fragmented as a health system. Colleagues that were employees of our same health system had completely different email addresses, and firewalls would block important information we need to get to them because we weren't on the same email system. Something simple as that. We had 14 different versions of EMR systems, not only on the ambulatory side, but then you start looking at the acute care side, and it's entirely different EMR systems. And so there's been this huge concerted effort around putting everybody on a single platform, getting our house in order to make sure that we could better manage transfer data more accurately and more timely. And so I think that's been a huge lift. There's been hundreds of millions of dollars not only poured into the Texas division, but CommonSpirit Health as a whole is looking at this nationwide. And so for us, I think just aligning, making sure that our versions are updated, that we're able to effectively communicate as a healthcare provider team, I think is huge. And then so some of the technology that we've implemented, I'll cover in some later talking points, it has really helped us expedite that process and that engagement, not only with our own providers, but with patients as well.
No, that makes sense. And David, all the time that you've been at Jefferson and your experience in the industry, I'm sure you've heard a lot about from the technical side, the CIOs and the CDOs about, concern about migrating to the cloud and all this new, expense pressures around all the technologies. And, where do you see that going as a result of that?
Well, I was just reflecting, listening to an expert like Michael. So as you alluded to, David, I just got my Medicare card, so I'm feeling reflective. When I got to Jefferson as an assistant professor of medicine in 1990, there was no such thing as email. So we have over 410 listeners right now on this program. I wonder how many of them remember work when there was no email, right? So you want to talk about innovation? This is one guy's work life, what we have seen. And I have more computing power in this phone than the lunar excursion module that landed on the moon, right, in 1969. So I've seen it all, On the other hand, I still have 3 different MyChart accounts at 3 different provider organizations. So don't tell me that we figured this out, right? And we're still implementing EPIC at 1 or 2 more of our hospitals. I can't even say the word, so don't tell me. And I've been in practice for 35 years as a primary care general internist, and I still don't have a readily available icon-based registry of my own patients that shows me on a daily basis how I'm doing. Should I keep going? So, I started in 1990, no computer, no email, no voicemail. We bought a Radio Shack recorder and connected it to the phone so people could leave me a message, right? And here we are in 2021, a whole new world, obviously. And this slide is fantastic because why? At the bullseye of this slide is the thing we lack the most, which is leadership to get the job done. Maybe 500,000 deaths will get us to the point where we'll finally connect these dots.
No, that's absolutely right. Let's take a moment and check in with the audience and take a poll and see what they think of the primary roadblocks that they've had in transformation of healthcare. And I guess I could have included leadership here, but we'll leave that one off for now. Excellent point. So if each of you in the audience could just go onto your chat box and click one or more of the following. What do you think is the main roadblock in promoting digital transformation in healthcare in your organization? Is it the perceived cost? Is it resistance from providers, lack of a strong data protection, security, negligible policies, the incremental policies that have been occurring to boost adoption of new technologies, or the issue of just scattered data lying all over across the various systems unable to use? David, I can't help but share. I've not shared this with you, but when I went to my first business related industry, the person who was before me as chief medical officer, and this was at Aetna, Dr. Alan Savage, I heard stories that when he came in, he threw his computer into the hallway because he refused to use this newfangled email system as a method of communication. And that,
That's great.
he said, somebody wants to come talk to me, they can come make an appointment and not come
Right.
to
Of course. Right.
I actually called somebody with one of our young physicians when he asked me a question, and I called a colleague of mine right away, and I turned around half a minute later and told him the answer. He goes, "How did you find that out?" I said, "I called him." He goes, "You did what?" So the world changes. Yeah, I think this issue about technology is really going to change with the pandemic. And Mike, I would imagine you've been thinking the same thing.
Yeah, certainly. Yeah, it has been shocking. I think around the whole phone usage, we had one physician as we were talking about just further opportunities to engage patients through a digital platform. The conversation of an app and being able to FaceTime and or track or push notifications and surveys and things like that, where you're getting instant gratification feedback in the kind of this iPhone, me, this kind of era. This one provider had said, back in the 70s when I started and I just got out of med school, we didn't have cell phones. So if I had to call in an order or I had to call a patient or, and there wasn't a phone easily accessible, I literally walked around with a whole roll of quarters in my pocket. And just outside the physician's lounge, there'd be payphones and you'd have physicians lined up calling in orders after they're rounding on patients. And it just how far we've come and just where we're headed. It just things are moving at lightning pace. And these are exciting times, but that really does put things into perspective that not so long ago you had to walk around with a roll of quarters to even communicate effectively.
Absolutely. Well, let's check in with the audience. Looks like our poll is done and see what they think as the primary barriers to innovation. Interesting. Gentlemen,
Yep.
What do you think?
Yeah, well, I'm thrilled to see that the scattered silos, that's the biggest barrier. I totally agree. I mean, the others are important for sure, but the siloed situation. So I think, David Nace, this speaks to the power of the Innovacer platform. And I know we'll get to it later in the program, but being able to connect the dots across multiple systems, clinically in the laboratory, obviously, just connecting the laboratory to other clinical data sets, to the billing system, to the case management system, to the acuity management system, to any kind of artificial intelligence tool that we're looking at to help predict severity. I mean, imagine if we could link all of that. And I think that's what our wonderful attendees are getting at when they gave it a 74%, that's the major roadblock.
Yeah, what a mess. I heard that 80% of the data is just sitting out there and just not being used or accessed. So a tremendous opportunity. I know Mike's going to get into this a little bit later on. So one of the things with the pandemic, which has been often called the great accelerator into digital health, is this idea of, a shift in where care may be delivered. And I think the experience of care is different, right, as we get into the home. I know, David, you've talked about that for years with Steve Pasco.
You bet. Well, I'm excited to see this. This is a great graphic, and your eye is just naturally drawn to the upper right. And, lots of people, in addition to David Nash, think that care is going everywhere but the hospital, and of course, Steve Klasko has popularized the idea of where's Jefferson? It's everywhere. It's on my phone. It's on my computer. It's at the urgent care center. Oh yeah, and there is this hospital downtown too. I totally drank that Kool-Aid, helped to make it and drank it. But beside that, I think he's right. Getting people out of the hospital, helping us to age carefully at home, connecting to us. I see the mass customization and continuous connectivity. I also see connectivity as a vital sign. And I've been talking more and more about this in the last month even, that we got to take a history, and that history has to include, are you connected to the internet? And look, my daughter, who's a attending hospitalist, she gets this. It's old guys like me that we have to retool and understand that connectivity, connecting to the internet, is a vital sign for patients, which will enable us to do remote patient monitoring, telehealth, senior care, aging in place, and population health with wearables, which, if you look at this great diagram, that's a high patient autonomy, lowering cost, and I would argue improving value. And you've got that on the y-axis on the far left here, quality of care experience. So I hope we can create this vision. It's not going to be easy, but sure makes a lot of sense to me.
Yeah, I just was talking to John Halamka the other day. He's doing some work at Mayo, and they've been delivering a hospital in the home, if you will, telemedicine, wrapping around acute care, chronic patients.
Right.
They've not had, over 6 months of data, they've not had one single episode of sundowning. Can you imagine that? And
that's incredible.
Unbelievable.
Yes, well, the Mayo experience with the company Medically Home, that's reportable. I'm helping several other companies in the remote patient monitoring space now, and the delivering chronic care at home. Jefferson Health is delivering all kinds of services in the pandemic that at home, which we really had done very little of that prior. So all of this, I think, is really the platform for change, certainly. I think there's other issues here, David, maybe we'll talk about later. What's the quality of the services we're delivering at home? What are the right outcome measures? How do we measure these? How do we close the feedback loop outside of the delivery system in the four walls of the hospital? So it's certainly something that's going to occupy a lot of energy moving forward.
Absolutely. Well, Mike, you're arguably the youngest of the three of us, so you're probably the best and closest defining this idea, like, what is digital health? Everybody's asking us.
Yeah, this is a really good slide, and there's a lot going on here. I think ultimately, to just sum it up, I think it's coming up with strategies, technologies, infrastructure, really to not only engage your patients but your providers and improve outcomes while reducing the cost of care and doing it in an efficient manner. It's not just you've got to have that core, and part and parcel. Hospitals exist; they cater to certain needs. Surgeries, all those things are still going to happen, and that is, but payers are now requesting, and Medicare pushing everybody to risk now, right? All of these new innovative models that are coming down the pike with the GEO direct contracting model, they want value. And so in order to get that value, you've got to demonstrate that deeper level of engagement with those patients, and you've got to bring those physicians along. And so this type of platform, and what's shown on the slide is there's a lot of things that you can do moving into that digital health platform. And so I think for us, it's just understanding what's out there today and where there are opportunities to innovate. There are some things that you're doing that are homegrown that are great, and you need to accelerate those things. I think to the previous slide with home health and some of those things, we had relationships with home health providers, but it became extremely critical to work with the best home health care providers when it came to freeing up beds and having capacity, because we were going through these surges of COVID-19. And so we started partnering with the best of the best home health agencies and started looking at what type of assets they had in place on digital telehealth monitoring, those types of things, Bluetooth devices. So all of those things come into effect, not only in the acute care setting, but across the continuum of care. And I think this slide, to me, illustrates that there are a multitude of avenues that you could pursue, all at different stages, that'll get you to that deeper level of engagement, that accountability to not only to your patients, but to the payers and to the government as well.
Yeah, David, if people are going to take this new GEO model and really truly go into full risk, which what GEO is all about, I mean, I would imagine that you can't sit around with 80% of your data not even being accessible.
No, of course not. And this is the lifeblood of any organization now, especially those that are going to, bear economic risk for clinical decision making. I want to focus on this incredible slide for a moment because, clearly there's a lot to be done here. But if you look down at the bottom where it says transform the care continuum, data-driven standards, optimize clinical processes, this is where I've been working for 30 years at Jefferson. And as I like to say, David Nace, people who know me, when I got to Jefferson, I was 6 feet, 2.5 inches tall. Now I'm barely 5'6". And the reason is you get worn down trying to data-driven standards of care, optimize clinical processes. Them's fighting words to folks who were trained like you and me to be autonomous decision makers, not understanding the complexity of the system's nature of care. Let's also realize that another overlay on this fantastic diagram is about a third of what we do right now, everywhere but CHI and Jefferson, about a third of what we do is of no value. And if you look nationally, well, that's roughly $1 trillion. Imagine if we could reallocate even a fraction of that money, right? Well, we'd never have a shortage of PPE again. We'd never have a shortage of ventilators again. We'd never have a shortage of connecting people in the community to our telehealth platform because everybody gets an iPad again, right? So it all looks great until you're at the ground level and you got to deal with doctors, nurses, pharmacists, and others who've been doing it their way for a long time. So if we can get closure of the feedback loop with good data in a non-punitive way to change behavior, that's really, I think, the leadership issue as it relates to transform the care continuum. I'm still spinning around this wheel you got here to transform the care continuum.
There's a lot to be doing, and certainly the pandemic has put focus on this, and clearly the cost savings can be tremendous if you're able to do this and get into the cloud and really rationalize all those fragmented stovepipe systems that you have. If we look at this survey from BDO, Center for Innovation, they're looking at, with the result of the pandemic, what's the current focus, short-term and long-term? And Mike, it's very interesting. The patient experience is top in the short term, but improving the operational effectiveness and modernizing technology are for the long term.
Yeah, it is. And I think that's crucial. I think with just the pandemic and folks switching over, we had to do a lot of training and education with our physicians to fully transition away from in-person visits to this virtual platform. And you figured, okay, it's great. I've got my doctors trained. We're good to go. And then you get, an 87-year-old patient on the other end, and they can't get the video to work. So it then turns from a video conference to a teleconference or a phone-based, visit. And so we quickly realized, oh my gosh, it's great that we trained up our doctors, but they're not IT specialists. And what do we need to do to help preempt some of those things? Our doctors are there to practice medicine, great medicine. They don't know to download Windows 10 and upgrade and X, Y, and Z. So what we quickly discovered is we've got to train up our staff, and we've got to prep these meetings much, much better to do kind of these run-throughs with the patients. And so once we started getting the hang of that, providing some of that education, we started then surveying our patients. Do you like this approach? And I think with the impact of COVID and those surges, we were pleasantly surprised at their reaction, that they did like that they could show up to an appointment in their pajamas, and you'd never know. It's their head. I could be wearing shorts right now. You would never know. And so I think the convenience that they've had is it has really shown through. I mean, it really kind of showed that we were focused on providing better care. There were some other things we did also to reassure our patients, right? So if you have to come in, we're available, but we send out automated messages and personalized messages to patients to say we're deep cleaning our office area, our waiting rooms every single night, and had videos and showed them what we were doing. And I think that was all very reassuring, and that's really helped with patient satisfaction. With all of this technology, it could be overwhelming. And so I think we've got to work smarter and not necessarily harder, but make it easier, on the surface to be able to digest. We know behind the scenes, this is very complex stuff. There's a lot of moving parts to this, but I think the end user has to feel comfortable, and it has to be made easy. If I've got to click 10 times to close a metric or to log into my Zoom call, I'm just not going to do it. I've got better things to do. So anyway, yeah, I think patient satisfaction, if you can get that up and running and you can provide that convenience factor, it's going to pay dividends, not only from an experience standpoint, from a loyalty, from a keepage perspective, it's going to pay off.
I think to do all this, if we talk about a path, originally EHR was the center of everything for innovation, but there seems to be a path forward. David, do you think the EHR can transform, or do you think there's a new potential solution to how we think about this as an enterprise?
Wow. Well, this is a great graphic too. And I like the evolution from stage 1 to stage 4 here. Pretty cool. Well, look, the electronic health record, I wish it were that, right? It's not that now. It's the electronic medical record designed to capture the codes, do the billing, keep track of who's seen who. So I think we got to get to the next generation just as fast as possible. And I recognize that there's work out there to do that with all kinds of new toys. The other aspect, even in stage 1, is giving us an opportunity to profile physician practice patterns and see which pattern leads to the best performance, and then being able to benchmark that performance. So it's not just closing gaps in care, but showing us which trajectory of care and which combination of test resources and visits has led to the best outcome, and using artificial intelligence to evaluate that. I think the initiatives focused on visualization of care, well, great. If we could connect remote patient monitoring in real time and have AI that will evaluate what it is we're seeing, so we're given an appropriate warning at the appropriate time. Hey, it looks like today's sugar's way out of whack. What'd you have for breakfast? And that could be automatic, and the doctor's engaged once there's real questions about what's the therapy. So I'm excited about that. And then getting all the way to stage 4, comprehensive enterprise-wide transformation strategy. Well, cool. I hope I'm around to see it. Sounds fantastic. And I know that our place and many others are making the kind of investment to eventually get us to stage 4. But let's not forget, it took a long time to go from no voicemail, no email to where we are today. I don't have another 30 years. That's, I guess, my selfish point. I hope we could do this in a lot fewer years than it took us to get to where we currently are. I'm pretty confident. We got young guys like Mike and others at the helm to get this done. That's exciting, very exciting. But I'm a realist too.
Absolutely. We've talked a lot about how data is the key to this, right? Good data allows organizations to do all kinds of things and manage such a forward motion into thinking about new ways of innovation. And we've talked about interoperability. How do you connect all these systems and get them to work? Because there's always going to be various systems. So, wow, this is an interesting slide. Mike, what are your thoughts about true interoperability? Have we achieved it? Are we getting close?
No, I think we're taking steps to that, but we're in the crawling stage, I think. It just depends on where you're at. I look at this slide, and I even look at my own network of providers. We have over 2,000 physicians, and I've got some folks that are highly integrated, have the connectivity, have the data feeds flowing in. You walk into their lobby, and there's an iPad, and if you want to take a sample survey, it's there for you. If there are certain services you like, there's this really nice iPad that you get things. And when you're discharged, you get a nice Bluetooth device. If you have CHF, there's a nice little scale that goes home with you. And then I've got the provider sitting in Lake Jackson who has 100 of my patients who is paper-based. Doesn't use email, so you can't send anything via email. When they have to report, if you're requesting to pull charts or anything like that, you've got to send it via snail mail. And so there's this huge gap, and we find that in every corridor, every market, we have those one or few physicians that aren't fully integrated. But I do think that what COVID-19 has done is pushed us all together to really start looking at who we can partner with to pull in this information to make a lot of these things actionable. And I look at this graphic, and certainly the pharmaceutical industry, laboratories are more important now than ever when folks are missing their A1Cs and not getting their labs drawn. How do we spearhead some of those initiatives? Are there at-home testing available to help mitigate some of the concerns patients have with physically going to a location? So I do think we are much further along. I do believe in the next 3 to 5 years, we will see some huge innovative strides to get to that point. And I'm optimistic about the future.
No, I mean, I'm optimistic too. I think we all are. And I think, David, when we talk about interoperability, the way Mike did, we often think about integrating the clinicians, right? Primary care, tertiary care radiologists. We probably left the payer off this slide because the provider really has to communicate in fairly secure and real time with payers, and every provider has multiple payers. And then we want to get, as we move to personalized medicine, get more people enrolled in the right trials and get good research once the drug's out there in the field. So lots of connections that need to happen here.
Yeah, and lots of workarounds too. I mean, this is a great vision for interoperability. Fantastic. And as I said a little while ago, I hope I live to see it. I mean, Mike gave some great examples of folks who are sort of off the grid as it relates to this drawing. Even in a faculty practice plan where everybody's on the same platform, connecting the dots to home care, to the telehealth, we still can't do all that seamlessly. So if we had a platform where we could then connect everything that's on this diagram, that would be spectacular.
Well, the future may not be so far away, David, and I think Mike's going to talk about that. As we continue to use these new technologies during the pandemic with more virtual care, we're learning, we're starting to look at data differently. So let's just check in with our audience and see where they think their organization is in this process of digital transformation. So if you could each go into the chat box and just answer this question. Where do you think your enterprise is in this process? You don't know where to start. You started some planning, you're looking for the right partner, you're working through some changes with your current vendors, or you're all set and you're completely digital transformed. That would be interesting. While we're waiting for the audience, I have a couple questions from the audience for two of you gentlemen. So one person says here, putting everyone on a single platform is an unreachable dream. Mike, you want to comment on that?
Yes, I agree. I don't think that's ever going to happen. I'd be much more happier going from 65 EMRs to 30. And even with 30, there's got to be some workarounds. But I do think there needs to be some sort of consolidation. And if not, and if that is too costly, are there applications out there that are able to consume that data so that you could place it into some sort of a data warehouse and are able to make that data actionable? So I've seen that as an approach. We're not fully integrated, and we may never will. We may not be. But there are tools, there are applications, there are things out there. Even working with Innovator, we've come across that as a barrier and have been able to solution for that. So I agree with that statement. We'll never get to a perfect state.
Yeah, I think often people don't understand necessarily or mean the same thing when they say platform. I know David, our friend John Jenrette used to say, I love to stand on my platform to be able to tell you. So platform is often construed as an EMR versus some of these cloud-based initiatives or platforms on platforms. David, there's another question in here. Inherent to value-based care arrangements is the idea that payment is tied to meeting certain quality and performance metrics. Are providers still being required to meet these same metrics even during the pandemic? And how about in the future?
Well, so most of our attendees know they were not held to these metrics largely during the pandemic, at least at the national level. Certainly, most CMS measures were delayed. A lot of managed care measures were delayed. I think the measures will come back, and perhaps they may come back with a vengeance. We have to see what our new CMS administrator, Chiquita, and her team, our new CMMI leader, Elizabeth Fowler. It's going to be fascinating to see their view. I think we need better, more agile ambulatory measures of quality. And the digital transformation will be directly connected to that for sure.
Yeah, absolutely. Well, let's go in and check in with our audience and see what the poll result was in terms of their current status in this transformation. Can we pull the poll up?
Wow.
Interesting. Yeah. Most people just starting to plan, or they're working through some changes. Still sounds like starting to plan. So, and then the last one's not a surprise, right? So let's see where this goes. Very interesting. All right, Mike, tell us a little bit about your organization. You've got a great case study here about work you've done. Tell us about it.
Yeah, certainly. So I have the great fortune of belonging to the largest faith-based health system in the country, known as CommonSpirit Health. It essentially was formed through the merger of Catholic Health Initiative, CHI, and Dignity Health out of the West Coast. And some really impressive facts here. You can see we're spread across 21 states, 20 million patients visited annually. Those are huge numbers. And for us, like I said, it's a giant organization, but incredibly well connected. I feel very well connected to my colleagues. They're doing some of the same type of work in Fargo, in Arkansas, in Southern California, Iowa, Nebraska. So a lot of that move and shift towards digital transformation, technology, data sharing, enterprise reporting has really brought us much closer together, and we've shared best practices and techniques through weekly conversations and webinars such as this one, but with our own leadership. Shifting over to the right, you can see CHI St. Luke's, and we're in a very competitive and aggressive market, but we've got great friends, neighbors, and colleagues also listed on that screen. And you can see we cover a large footprint in a very competitive market. So 27% of the population of Texas is being served in localities where we are present. And we've got 16 facilities servicing 22,000 square miles. We've got crucial partnerships with 2 large academic medical groups in Texas A&M and the Baylor College of Medicine, work closely with Texas Children's Hospital. So just a lot going on. It's a big organization and part of that complexity when it comes to managing population health. So we go to the next slide. Love to maybe just dive into a little bit about us. And so I oversee the Clinically Integrated Network and Accountable Care Organization. We actually have 2 of them, but we work in unison, and oftentimes they are now transitioning towards contracting as one entire entity. But there are over 2,000, I think as of today, 2,085 physicians within our Clinically Integrated Network spread across 16 hospitals. We've got the Baylor College of Medicine, world-renowned, known for innovation, a lot of research, huge in genetics, just a phenomenal group to work with, and one of our partners. And then we've got our medical groups, which are aligned with some of these large academic institutions, depending on the market that they're in, and then over 900 independent physicians. So it is a large group. If we go to the next slide, I wanted to just highlight very quickly some of the things that we've done in this age of digital transformation and moving down that track. And we're not as advanced, so whoever scored 5% or you're there, I'd love to talk to you because that's phenomenal, and certainly would love to hear more about what you're doing, but thank you for sharing those results. For us, going back to patient-centered, patient-focused care, you've got to have care management. You've got to be able to engage those patients at the point of care, where they live, in person, and now more often virtually. And so we constructed every group, every organization, every CIN has care management protocols. I mean, you've got to have that in order to be successful. That's what the payers are looking for. That's what Medicare is looking for. We've now really started looking at how we're able to alert patients, how are we able to access information timely, real time, to do something to impact that care. So there's systems like Patient Ping. We used another vendor a while back, had not used Innovaccer, and they could not consume Patient Ping data. So I had care managers that were working in 2 different systems, duplicating work. Now, in their work queue, as they log in and they use the InCare application, all of that information is there. It's at their fingertips. They're able to share information back and forth with the practices and with the patients. Text messaging is something we've used heavily in different campaigns. And now we're developing a patient app working with Innovaccer that we're going to roll out and focus on service lines. We're going to focus on some of our high utilizers of the emergency department. And this is an application that our care manager can easily push to a patient to utilize and install. And they can do it over the phone while they're calling and conversing with that patient, or our case managers at the bedside in our orthopedic unit can install that app, make sure that that patient gets that, and then 2 days after discharge, they get a pain survey. They get a call with their surgeon. We can do med reconciliation because we've loaded that data into the application. There are videos on stretching or how to maintain, your sutures. All of that stuff is things that we could put in the hands of patients relatively easy. Not even the patient, their caregivers as well. So maybe my 75-year-old mother doesn't have a smartphone. She's got a different type of device, and those alerts will come to me. I could be part of that care team. Off to the right are just some of these campaigns where we really saw some success. What we decided to do once the pandemic really started to take off, and we knew it was on U.S. soil, and we started seeing the Pacific Northwest really get hit hard with those nursing homes, we knew it was inevitable and it was coming, we started proactively working with Innovacer and our primary care physicians to record personalized messages to our patients, to reassure them that we are taking all necessary precautions to keep them safe, to keep our staff safe, to clean and sterilize our areas. We also then started campaigns around wellness visits. And when we talk about quality, many of the payers and Medicare really took a step back and said, we've got to focus on patient care first and foremost. And these metrics are important, but that's not the primary focus. What we started noticing is a change in our ability to close certain metrics because of our limitations of face-to-face interactions. But then we saw a huge increase and a huge focus around mental health and depression screenings and those types of things. And so those campaigns where you get a personalized phone call from your provider saying, just wanted to let you know we're open for business. If you're interested and want to set up a virtual call, please press 0 and it'll route you to our front desk so we can schedule your wellness visit. And we saw a huge uptick. We actually did more wellness visits in 2019 than we've ever done because we had moved and transitioned into this virtual platform now. That engagement before we do a campaign, we did something around colonoscopies and colon cancer screenings. That to us was huge because, one, it's a very sensitive topic. If my physician were to mail me a colorectal cancer fit test, screening test, and didn't really explain to me why I was getting this, I'd panic. I'd probably talk to my wife, oh my gosh, my doctor thinks something's wrong, and it's not that. So we had really good information collateral 2 weeks prior to automating and sending out those kits with a personalized letter from the physician. We had a voice recorded message from the physician saying, we want to make sure we get this test to you. It's an annual requirement. And of course, we've done our research. We've checked, and we know who's had colonoscopies and who hasn't. And so we started very small. There were about 500 patients we targeted in this huge coordinated effort with a large national lab, Innovacer, and our primary care physicians really driving this initiative. And that messaging out front helped that adoption rate, helped that completion rate, and a quarter of those results were coming back in quickly. And as we tweaked things, we saw that completion percentage and gap closure increase steadily. One story that really stuck out for me was our focus was too narrow, right? We were only focused on the Medicare population because claims data said we had to close that gap. Had a physician say, I've got a 36-year-old mother of 2, came in complaining of pain, abdominal pain issues. Can I get her a test? Can you send her a test? We overnighted it, got her all the information she needed. Unfortunately, the test came back positive. And did the colonoscopy and found out that it was stage 4 colon cancer. And unfortunately, this lady only had a few more months to live. And one of the things that really hit me was this physician told me the story, and then happens to be one of our board members, talked to our board about the need to speed up our timeline and really address a broader population. We know who needs these tests. Let's do it. And the takeaway from that story was, because we started focusing on one thing, we were able to impact this person's life. And she spent her last Thanksgiving and her last Christmas with her young children, went to Florida, had a great vacation, came back, and several weeks later, unfortunately passed. We have come back now and expanded our scope to be much more aggressive and push out 6,000 of these kits a month, touching multiple populations, multiple age groups, to ramp up this effort. So I think it makes a difference, and it's something that our physicians have seen work.
So lots of interventions, lots of accomplishments. It sounds like the pandemic's really provided an interesting learning experience for you. I know that you've talked about data being the key to this, and I just want to say I'm getting a slew of questions here from the audience about, like, how do you get to a patient-centered data model? How do you use the cloud to access data? One of the biggest roadblocks in my limited experience has been lack of confidence in using predictive analytics based on the quality of the data. David, I would imagine you often hear these same things.
Sure. So, caveat emptor, that's a big part of this too. who's the right partner you need to do all this. I mean, today's not the time to get into who are the 10 AI best vendors, but this is the model right here, right in front of us. And the Innovacer platform is the platform to create care as one. In my view, that you could get it all in one with one tool.
And Mike, I know we've often talked about this whole concept of how do you create patient-centeredness, and it really is the infrastructure that you have to be able to do that in.
Yeah, certainly. I mean, you've got to have engaged providers, and a lot of anything that we do with our physicians, they've got a seat at the table when we roll out something new that's technology related or even changing up a process. And so I think having that buy-in first and foremost, but I do think the technology also helps. I will tell you, our medical group does not do outbound calls. We will take patient phone calls all day long, but we just don't have the manpower to have a call center to do outreach to patients. And so we've used these digital tools to create that pool and to create that engagement. So those messages are going out, patients are able to press 0, we could focus on campaigns, we could send text messages, and that new level of engagement has really sped up and increased a lot of those visits. So it helped us rebound much faster from the decreases in census that we had previously seen.
Clearly getting your stakeholders aligned together. And then I think when you look at both the population and patient level, David, you've taught me much over the years about the concept of being patient-centered. I know this slide often rings true, and this is our view at Innovacer of how we provide a cloud-based solution, but isn't the comprehensive patient view the key?
Well, to me it is. I mean, this is beautiful, and I'm glad it's at the end of our time together, but putting the patient in the center of all of this is really what it's all about. Again, as long as they're also connected and making connectivity a vital sign and a core component of making all this work. I wish we had time to answer, a slew of the questions, but to me, the AI-assisted decision support, the care coordination, but also as the primary care doctor, and it's the top of your list on the left-hand side, I got to make sure I can see all this happening and I can figure out how to do it, and I don't need a software writer on my side or my 30-year-old son as my technical consultant to make it work. I have to be able to access this seamlessly, and the patient needs to be a part of this without any friction as well. That's the vision.
And not to underscore this whole social determinant of health and integration with community-based organizations. Gosh.
You bet. You bet.
So critical. David, you once told me when you come to work, there are 3 things you want to know. Did you remember that conversation?
I sure do. Of course. Yeah, well, among the things I want to know is how am I doing? And more importantly, how are my patients doing? And how are they doing relative to the gal or guy on either side of me? How are we all doing? Because at the moment, we have no idea. And Mike's great story about providers in his network who still don't do email, that's a clinically integrated network, with all due respect, not. So I'm just focused on the folks in our practice and who's in the exam room on my left and who's in the exam room on my right, and what exactly are we all doing each day. At this moment in time, we know very little about that.
Yeah. Gentlemen, thank you both very much for sharing these stories. Mike, it sounds like you brought St. Luke's and the clinically integrated network a long way. We've been answering some of the questions as we go along, and tremendous work you've done, David, talking about population health management, teaching us all across this country about that. Certainly those learnings have gone into Innovator's platform and has gone into the work at CommonSpirit as well. So gentlemen, thank you both very much for your work.
Thanks again. Fantastic.
Many thanks to the audience dialing in and participating as well.
Thank you.
Thanks, Mike. With that, this concludes the webinar. Everyone have a great day.